Hello friends, today we will gain knowledge about drugs acting on peripheral nervous system, and our main objectives will be to know about the skeletal muscle relaxants, to study about the mechanism of action of skeletal muscle relaxants and the drug Tubocurarine, and to know about local anesthetics, its action and the drug Procurarine. First, let me give introduction of skeletal muscle relaxants. Skeletal muscle relaxants are drugs that act peripherally at neuromuscular junction or muscle fiber itself or centrally in the cerebrospinal axis to reduce muscle tone or cause paralysis. The neuromuscular blocking agents are used primarily in conjunction with general anesthetics to provide muscle relaxation for surgery, while centrally acting muscle relaxants are used mainly for painful muscle spasms and spastic neurological conditions. Neuromuscular blocking drugs are used to produce muscle paralysis in order to facilitate surgery or in intensive care units for artificial ventilation. They interfere with transmission at the neuromuscular junction and lack central nervous system activity. Peripherally acting muscle relaxants has been divided into two types. First, neuromuscular blocking agents, which include non-depolarizing blockers and depolarizing blockers. And second is directly acting agents. Now we will see the mechanism of action. The site of action of both competitive and depolarizing blockers is the end plate of skeletal muscle fibers. Competitive block is produced by curare and related drugs. Claude Bernard precisely localized the site of action of curare to be the neuromuscular junction. He stimulated the sciatic nerve of frog and recorded the contraction of gastrocnemius muscles. Injection of curare in the ventral limb sac caused inhibition of muscle twitches, but there was no effect if the blood supply of the hind limb was occluded. This showed that curare acted peripherally and not centrally. Soaking a portion of the sciatic nerve in curare solution did not affect the twitches, and a curarized muscle still responded to direct stimulation. Thus, nervous conduction and muscle contraction were intact. The only possible site of action could be the neuromuscular junction. This has now been confirmed by close iontophoretic application of DTC to the muscle and plate and by other modern techniques. The competitive blockers have affinity for the nicotinic cholinergic receptors at the muscle and plate, but have no intrinsic activity. The nicotinic receptor is a protein with 5 subunits which are arranged like rosettes surrounding the sodium channel. The 2 alpha subunits carry 2 acetylcholine binding sites. These have negatively charged groups which combine with the cationic head of ACH. Hence, opening of sodium channel is produced. Most of the competitive blockers have 2 or more quaternary sodium atoms which provide the necessary attraction to the same site, but the bulk of antagonistic molecule does not allow conformational change in the subunits needed for opening the channel. In depolarizing block, decamethonium and SCH have affinity as well as submaximal intrinsic activity of the nicotinic cholinereceptors. They depolarize muscle and plates by opening sodium channels and initially produce twitching and fasciculations. Because in the focally innervated mammalian muscle, stimulation is transient, longer-lasting depolarization of muscle and plate produces repetitive excitation of the fiber. in the multiply innervated contracture muscle. Stimulation is prolonged, resulting in sustained contraction. These drugs do not dissociate rapidly from the receptor and are not hydrolyzed by ACHE. They induce prolonged partial depolarization of the region around muscle and plate. Hence, sodium channels get inactivated, causing ACH release from motor nerve endings is unable to generate propagated MEP, hence causing flaccid paralysis in mammals. In other words, a zone of inexcitability is created around the end plate, preventing activation of the muscle fiber. Now, some of its actions. On skeletal muscles, intravenous injection of non-depolarizing blockers rapidly produce muscle weakness followed by flaccid paralysis. Small, fast response muscles are affected first. Paralysis spread to hands, feet, arm, leg, neck, face, trunk, intercostal muscles, and finally diaphragm. Respiration stops. The rate of attainment of peak effect and the duration for which it is maintained depends on the drug, its dose, anesthetic used, hemodynamics, renal and hepatic status of the patient, and several other factors. Recovery occurs in the reverse sequence. Diaphragmatic contractions resume first. In general, the more potent non-depolarizing blockers have a longer onset of action. Depolarizing blockers typically produce fasciculations, lasting few seconds before inducing flaccid paralysis. But fasciculations are not prominent in well-anesthetized patients. On autonomic ganglia, because the cholinergic receptors in autonomic ganglia are nicotinic, competitive neuromuscular blockers produce some degree of ganglionic blockade. DTC has the maximum propensity in this regard, while the newer drugs, for example, Vicurinium, etc., are partially devoid of it. SCH may cause ganglionic stimulation by its agonistic action on nicotinic receptors. Histamine release. DTC releases histamine from mast cells, thus does not involve immune system and is due to the bulky cationic nature of the molecule. Histamine release contributes to the hypotension produced by DTC. Flushing, bronchospasm, and increased respiratory secretions are other effects. Intradermal injection of DTC produces a wheel similar to that produced by injecting histamine. On CVS, Tubocurarine produces significant fall in BP. This is due to ganglionic blockade, histamine release, and reduced venous return, a result of paralysis of limb and respiratory muscles. Heart rate may increase due to the vagal ganglionic blockade. Pancuronium and vicuronium also tend to cause tachycardia. All newer non-depolarizing drugs have negligible effects on BP and HR. Cardiovascular effects of SCH are variable. Generally, bradycardia occurs initially due to activation of vagal ganglia, followed by tachycardia and rise in BP due to stimulation of sympathetic ganglia. Prolonged administration of SCH has caused cardiac arrhythmias and even arrest in patients with burns, soft tissue injury, and tetanus. Efflux of intracellular potassium occurs in these conditions, which are augmented by prolonged depolarization of skeletal muscles. Now on GIT, the ganglionic blocking activity of competitive blockers may enhance post-operative paralytic ileus after abdominal operations. Now we will study about Tubocurarine. Tubocurarine is a toxic alkaloid historically known for its use as an arrow poison. In the mid-1900s, it was used in conjunction with an anesthetic to provide skeletal muscle relaxation during surgery or mechanical ventilation. It's now rarely used as an adjunct for clinical anesthesia because safer alternatives such as Cistocurarine and rocuronium are available. Tubocurarine is a naturally occurring monoquaternary alkaloid obtained from the bark of the South American plant that is Chondrodendron tomentosum, a climbing vine. Structurally, tubocurarine is a benzyloquinoline derivative. 45 seconds after the beginning of the injection, heaviness of the eyelids and transitory diplopia were perceived. At the completion of the injection, diplopia became fixed but could be noticed only when the subject's eyelids were raised by the operator. As curarization proceeded, it seemed to the subject as if the facial muscles, those of the tongue, pharynx and lower jaw, the muscles of the neck and back, and the muscles of the extremities became released in about that order. Shortly after the injection was completed, the subjects experienced a sensation of increased difficulty in breathing, as if an extra effort was necessary to maintain an adequate respiratory exchange. It reached its maximum after 5 minutes after the injection, coinciding with the maximum depression of the vital capacity. Tubocurarine has a time of onset of around 5 minutes, which is relatively slow among neuromuscular blocking drugs and has a duration of action of 60 to 120 minutes. It also causes histamine release, now a recognized hallmark of the tetrahydroisoquinoline class of neuromuscular blocking agents. Histamine release is associated with bronchospasm, hypotension, and salivary secretions, making it dangerous for asthmatics, children, and those who are pregnant or lactating. However, the main disadvantage in the use of tubocurarine is its significant ganglionic blocking effect that manifests as hypotension in many patients. This constitutes a relative contradiction to its use in patients with myocardial ischemia. Now its uses. The most important use of neuromuscular blockers is as adjuvants to general anesthesia. Adequate muscle relaxation can be achieved at lighter planes. Many surgical procedures are performed more safely and rapidly by employing muscle relaxants. Muscle relaxants also reduce reflex muscle contraction in the region undergoing surgery and assist maintenance of controlled ventilation during anesthesia. They are particularly helpful in abdominal and thoracic surgery, intubation and endoscopies, orthopedic manipulations, etc. Vicuronium and rocuronium are the most frequently selected non-depolarizing blockers. Critically ill patients in intensive care units often need ventilator support. This can be facilitated by continuous infusion of sub-anesthetic doses of a competitive neuromuscular blocker, which reduces the chest wall resistance to inflation. Vicuronium is the most commonly used, but after prolonged infusion, it can cause blockade lasting 1 to 3 days due to accumulation of an active metabolite or development of neuropathy. Convulsions and trauma from electroconvulsive therapy can be avoided by the use of muscle relaxants without decreasing the therapeutic benefit. SCH is most commonly used for this purpose. The short-acting competitive blocker mivacurium is an alternative. Severe cases of tetanus and status epilepticus who are not controlled by diazepam or other drugs may be paralyzed by neuromuscular blocker and maintained on intermittent positive pressure respiration till the disease subsides. Now, centrally acting muscle relaxants. These are drugs which reduce skeletal muscle tone by a selective action in the cerebrospinal axis without altering consciousness. They selectively depress spinal and supraspinal polysynaptic reflexes involved in the regulation of muscle tone without significantly affecting monosynaptically mediated stretch reflex. All centrally acting muscle relaxants do have some sedative property. They have no effect on neuromuscular transmission and on muscle fibers, but reduce decerebrate rigidity upper motor neuron spasticity and hyperflexia. Now we will study about local anesthesia. Local anesthetics are drugs which upon topical application or local injection cause reversible loss of sensory perception, especially of pain in a restricted area of the body. They block generation and conduction of nerve impulse at any part of the neuron with which they come in contact without causing any structural damage. Thus, not only sensory but also motor impulses are interrupted when a LA is applied to a mixed nerve, resulting in muscular paralysis and loss of autonomic control as well. The clinically useful LAs are weak bases with amphiphilic property, a hydrophilic secondary or tertiary amine on one side and a lipophilic aromatic residue on the other, are joined by an alkyl chain through an estide or amide linkage. Now its mechanism of action. The LAs block nerve conduction by decreasing the entry of sodium ions during upstroke of action potential. As the concentration of LA is increased, the rate of rise of action potential and maximum depolarization decreases, causing slowing of conduction. Finally, local depolarization fails to reach the threshold potential and conduction block ensues. The LAs interact with a receptor situated within the voltage-sensitive sodium channel and raise the threshold of channel opening. Sodium permeability fails to increase in response to an impulse or stimulus. Impulse conduction is interrupted when a sodium channels over a critical length of fibers are blocked. Potency of a LA generally corresponds to the lipid solubility of its base form, because it is this form which penetrates the axon. However, the predominant active species is the cationic form of LA, which is able to approach its receptor only when the channel is open at the inner face, and it binds more avidly to the activated and inactivated states of the channel than to the resting state. Binding of the LA prolongs the inactivated state. The channel takes longer to recover. The refractory period of the fiber is increased. Blockade develops rapidly when the nerve is stimulated repeatedly. The degree of blockade is frequency dependent. Greater blockade occurs at higher frequency of stimulation. Moreover, exposure to higher concentration of calcium reduces inactivation of sodium channels and lessens the degree of blockade. Now, some of its local actions. The clinically used LAs have no or minimal local irritant action and block sensory nerve endings, nerve trunks, neuromuscular junction, ganglionic synapse and receptors. That is, those structures which function through increased sodium permeability. They also reduce release of acetylcholine from motor nerve endings. Injected around a mixed nerve, they cause anesthesia of skin and paralysis of the voluntary muscle supplied by that nerve. Sensory and motor fibers are inherently equally sensitive, but some LAs do exhibit unequal ability to block them. For example, bupivacaine produces sensory block at much lower concentration than that need for motor block. The sensitivity to LA is determined by diameter of the fibers as well as by the fiber type. Diameter remaining the same, myelinated nerves are blocked earlier than non-myelinated. In general, small fibers are more sensitive than larger fibers. Smaller fibers tend to have shorter critical lengths because in them voltage chains propagate passively for shorter distances. Also, more slender axons have shorter intermodal distances, and LAs easily enter the axon at the nodes of Rennes. The density of sodium channel is much higher at these nodes. Moreover, frequency dependence of blockade makes smaller sensory fibers more vulnerable since they generate high frequency, longer lasting action potentials than the motor fibers. Thus, fiber diameter itself may not govern sensitivity to LA. Autonomic fibers are generally more susceptible than somatic fibers. Among the somatic afferents, order of the blockade is pain, temperature sense, touch, deep pressure sense. Applied to the tongue, bitter taste is lost first, followed by sweet and sour, and salty taste last of all. In general, fibers that are more susceptible to LA are the first to be blocked and the last to recover. Also, location of the fiber within a nerve trunk determines the latency, duration, and often the depth of local anesthesia. Now, its systemic actions. Any LA injected or applied locally is ultimately absorbed and can produce systemic effects depending on the concentration attained in the plasma and tissues. On CNS, all LAs are capable of producing a sequence of stimulation followed by depression. Cocaine is a powerful CNS stimulant, causing in sequence euphoria, excitement, mental confusion, restlessness, tremor and twitching of muscles, convulsions, unconsciousness, respiratory depression, death in a dose-dependent manner. Procaine and other synthetic LAs are much less potent in this regard. At safe clinical doses, they produce little apparent CNS effects. High dose or accidental IV injection produce CNS stimulation followed by depression. The early neurological symptoms of overdose with lidocaine and other clinically used LAs are circumaural numbness, abnormal sensation in the tongue, dizziness, blurred vision, followed by drowsiness, dysphoria, and lethargy. Still higher doses produce excitation, restlessness, agitation, muscle twitching, seizures, and finally unconsciousness. On CVS, in heart, LAs are cardiac depressants, but no significant effects are observed at conventional doses. At high doses or on inadvertent IV injection, they decrease automaticity, excitability, contractility, conductivity, and prolong effective refractory period. They have a codeine-like antiarrhythmic action. Procaine is not used as antiarrhythmic because of short duration of action and propensity to produce CNS effects, but its amide derivative procainamide is a class IA antiarrhythmic. Bupivacaine is relatively more cardiotoxic and has reduced ventricular tachycardia or fibrillation. On blood vessels, LAs tend to produce fall in BP. This is primarily due to sympathetic blockade, but high concentrations as obtained locally at the site of injection do cause direct relaxation of arteriolar smooth muscles. Now, its pharmacokinetics. Soluble surface anesthetics are rapidly absorbed from mucous membranes and abraded areas, but absorption from intact skin is minimal. Procaine does not significantly penetrate mucous membrane. Rate of absorption depends upon the blood flow to the area of application or injection. The absorbed LA, being lipophilic, is widely distributed, rapidly enters highly perfused brain, heart, liver and kidney, followed by muscle and other viscera. Procaine is negligibly bound to plasma proteins, but amide LAs are bound to plasma alpha-1 acid glycoprotein. The maximal safe dose of LAs is lower in patients with hepatic disease and in the elderly who have decreased liver function. After oral ingestion, both procaine and lidocaine have high first-pass metabolism in the liver. Thus, they are not active orally for antiarrhythmic purposes. Now, procaine. Procaine is first synthetic local anesthetic introduced in 1905. Its popularity declined after the introduction of lidocaine, and it's not used now. It's not a surface anesthetic. Procaine forms poorly soluble salt with benzyl penicillin. Procaine penicillin injected IM acts for 24 hours due to slow absorption from the site of injection. Now, some of the use and techniques of local anesthesia. First, surface anesthesia. It's produced by topical application of a surface anesthetic to mucous membranes and abraded skin. Only the superficial layer is anesthetized and there is no loss of motor function. Onset and duration depends on the site, the drug, its concentration and form. For example, lidocaine sprayed in the throat acts in 2 to 5 minutes and produces anesthesia for 30 to 45 minutes. Second, infiltration anesthesia. Dilute solution of Ali is infiltrated under the skin in the area of operation. Blocks sensory nerve endings. Onset of action is almost immediate and duration is shorter than that after nerve block. For example, lidocaine in 30 to 60 minutes, bupivacaine in 90 to 180 minutes. Infiltration is used for minor operation, for example, incisions, excisions, hydrocele, herniotherapy, etc., when the area is to be anesthetized is small. Third is conduction block. The LA is injected around nerve trunks so that the area distal to injection is anesthetized and paralyzed. Choice of the LA and its concentration is mainly dictated by the required duration of action. Lidocaine with the intermediate duration of action is most commonly used, but for longer lasting anesthesia, bupivacaine may be selected. Fourth is spinal anesthesia. The LA is injected in the subarachnoid space between L2 to 3 or L3 to 4, that is below the lower end of the spinal cord. The primary site of action is the nerve roots in the cauda equina rather than the spinal cord. Lower abdomen and hind limbs are anesthetized and paralyzed. The level of anesthesia depends on the volume and speed of injection, specific gravity of drug solution and posture of the patient. The duration of spinal anesthesia depends on the drug used and its concentration. Spinal anesthesia is used for operations on lower limbs, pelvis, lower abdomen. For example, prostatectomy, fracture stitching, obstetric procedures and cesarean section, etc. And now fifth is epidural anesthesia. The spinal dural space is filled with semi-liquid fat through which nerve roots travel. The LA injected in the space acts primarily on the nerve roots in the epidural as well as subarachnoid spaces, to which it diffuses and small amount permeates through intravertebral foramen to produce multiple paravertebral blocks. This brings to end the lecture. Hope you have enjoyed. Thank you very much.